For those of you who have come as our guests, welcome, all of you, for having coming from long distances. We realize that, and your time is valuable, so we appreciate your being here. We want to tell you that this is the last day of a 3-day program. This three-day program was entitled Disarming Dialogues, Reviving Humanities in Medical Education. It came about because of a joint application made by the University of Chicago faculty and University College of Medical Sciences, New Delhi. I'm Vinay Kumar. I have the privilege of being the department chairman of pathology at University of Chicago, and partnering with Dr. Satyendra Singh, we put together a proposal for discussion of humanities in medical education. The proposal is funded by the University of Chicago. The University of Chicago, as many of you know, is a world-renowned institution of higher learning, in not just in medicine, but social sciences and all sorts of other things, law, business, et cetera, et cetera. And the University of Chicago aspires to reach towards India, to have interchange and collaborations. So this is a program designed to foster such interactions and collaborations. The first part of the program, until the Forum Theater that you saw, was closed. Closed in the sense that we invited, our colleagues in Delhi invited about 30 people from around the country to participate in it. And this started actually, as I said, on 2nd November. And we went through, on the first day, presentations by University of Chicago faculty about various aspects of humanities and humanities research, and various other things that we do there and how we think about it there. And then we had this 1.5 day of a forum theater and all other exercises, the Theater of the Oppressed, which was sort of designed for the same purpose, but a completely different tool system, method system. You saw the end of that just now. So at this point, we will have the last event of this three-day function. It'll be capped by a presentation by Dr. Monica Peek. And before she comes down here, I would like to give you a brief introduction of her. Dr. Monica Peek is a preeminent medical ethicist in the US, very young. She was listed as 40 amongst the best 40 in the country a little while ago. She got her medical degree from Johns Hopkins and also her master's in public health from Johns Hopkins, and subsequently a master in science and health services research from the University of Chicago. She serves on the faculty of the University of Chicago in the Department of Internal Medicine, where she provides clinical care. She's an active clinician who takes care of patients. She teaches medical students, and she also does health services research in the area of health disparities. Disparities are well known around the world. They are in Chicago, they are in India, they are in Delhi. You just have to walk a few blocks outside this place to see the disparities. So her passion really is to address the issue. It's a very humanitarian viewpoint. How do you address, how do you empower the dispossessed and the deprived? So her work has been on this, and she has received many grants from private foundations, from the government in the US to do the work. And the work that many of us do at University of Chicago in this area is marked by a rigor of scholarship which is measurable. It is not just based on what makes us feel good. It's based on what good we are doing and how can we measure we are actually doing good. And because we have a world-famous economics department there, we are helped a lot by our colleagues who know public policy, economic policy, healthcare economics, and so on and so forth. So Dr. Peek is she part of two different institutions within University of Chicago, the Bucksbaum Institute for Clinical Excellence in the MacLean Center for Medical Ethics. And she's the Director of Research at the MacLean Center for Clinical Medical Ethics and the Executive Medical Director of the Community Health Innovation for the University of Chicago Medicine. She has received many honors, including Greenwald Faculty Scholar, which is one of the highest awards in the field of medical ethics in the US. And she has been written up in Time magazine. I will not go through the list, CNN, various shows. She's been named as Outstanding Investigator from the Society of Internal Medicine. And she's an outstanding clinician, a passionate individual in the field of healthcare disparities and the aspect of humanities which we aspire to reach out to the underprivileged. Monica?
And so what I'd like to be able to do is to go through my slides, as I'm legally obliged to do, but also continue this really rich conversation, and to think about the ways in which we've reflected in our workshop over the past 3 days, but also just in the past few hours, about how different social roles that we occupy as people can affect our lives and our happiness, and ultimately, I would argue, our health, and what that means for us as clinicians, as most of us are in this room, or at least some part of the medical profession, to try and address some of these oppressions that people face, and to think about the healthcare system as a tool for addressing disparities as well. And how can we not just think about what we do when we're wearing a white coat, but what we do when we're technically outside of the healthcare system, but still carry our humanity with us and carry our identities as physicians, to sort of bridge both of those worlds. So I'm going to try and do that in the context of mainly talking or doing an introductory remarks just about the Ethics Center that we have at the University of Chicago. I joined the Ethics Center several years ago, primarily because I believe that health disparities are at its very essence an ethical issue. An ethical issue that we grasp or grapple with not only in Chicago and nationally, but globally. And it's something, this is my very first trip to India, and for the colleagues that I've been with over the past few days, they've seen me do nothing but gorge myself on the food and the artistry and the everything that's here in your wonderful country. But one of the things that's been particularly a stark reminder to me is the health disparities, or the visual social disparities that exist here in Delhi and the rest of the country that I see and that I face within my own country. So I actually feel very at home here for lots of reasons. Someone actually asked if I was part Indian, which was a wonderful honor. I'm not, but I almost said yes, just because I think it's great to be here. And so what I'd like to be able to do is to continue this dialogue that we've had over the past few hours and over the past few days about these really sort of challenging issues, but ones that I think that's in our power to address. So I'm going to actually, I have this slide in here twice, once at the very beginning and once at the end, and I'm not quite sure where we are. I sit in the Bucksbaum Institute, the MacLean Center for Ethics, the Department of Medicine. I'm a general internist, so I sit within the section of general internal medicine. And also we have a Center for Diabetes Translational Research at the university, where I'm one of the associate directors. And so some of the work that I'll talk about, or some of the things I talk about near the end, have to do with diabetes. And I became interested in diabetes because, to me, it's really a social disease, one that reflects the growing obesity epidemic, which is largely a lifestyle disease, and one which has the ability for multiple levers in our society to impact, both positive and negative. And so for someone who's interested in the social sciences, who's interested in patient engagement and lifestyle change, all of those things for me make diabetes interesting. So, but I think the lessons that I've learned over time are applicable to a wide variety of diseases. All right, so we'll start with just clinical medical ethics. And what that means. So this is a quote, and I have to also say that I'm only here because Dr. Mark Siegler couldn't be here. So to my delight, he is otherwise busy at the University of Chicago, and he really is heartbroken that he couldn't attend, and sends his best wishes. He is the director of our Ethics Center at the university. And these bullets come from a book chapter that he's writing an introduction to that I plagiarized here in bullet format. to just talk a little bit about clinical ethics. And so it's a medical field that's still relatively new within the past several decades that helps patients, families, and health professionals reach good clinical decisions by taking into account the medical details of the situation, the patient's personal preferences, values, socioeconomic considerations, and ethical concerns. And it really examines the practical ethical issues, the ethical concerns that arise routinely in encounters among patients, families, healthcare professionals, and healthcare institutions. So it's really where all of these kind of dynamics that we were discussing over the past few hours intersect with healthcare, with health systems, and with people's health. And we're sort of grappling with how we as clinical professionals try and deal with those issues. There's been a renewed interest in medical ethics within the United States for several reasons. One is sort of our horrible legacy of human experimentation and unethical research involving human subjects. One of the most famous of which is the Tuskegee experiment. And so that not only triggered the rise of institutional review boards and ethics committees in the US, but lots of other things as related to clinical practice within the United States. Civil and human rights. So starting from the 1960s to present, there is a new understanding that patients could and should be involved in medical decisions about their own care. And so patients aren't just something that we study or a body that hosts diseases, but they're people that we should be talking to and that should be empowered enough to interact with us as healthcare professionals. And then there have been a lot of technical advances that make us live longer and that can sustain our lives in ways that we didn't have the ability to previously. So that cure illness, delay death, and assist in reproduction that force us to grapple with some of the issues that we before didn't really have the opportunity to. The idea of playing God over someone's life and death, of assisting people having children when they couldn't before. And a lot of the other things that sort of arise are inherently clinical ethical issues. And so those sort of brought about a renewed interest in clinical medical ethics. This is a picture of the University of Chicago, which I invite all of you to come to sometime. The city is a wonderful, beautiful city. This is Dr. Siegler here in the middle. And again, I'm trying to embody his spirit, as well as some of the other associate directors at the MacLean Center for Ethics. So I just wanted to acknowledge them as my mentors and colleagues. And so the Ethics Center was established in 1982, so relatively not that long ago. It has more than 40 active faculty members from a range of institutions within the medical sciences as well as other parts of the university, so law school, business school, divinity school. These are all people that are actively faculty members at the MacLean Center. And since 1982, we've trained over 450 fellows. I can raise my hand as one of those, so can Rajna, who has participated in this year-long training to sort of really have the opportunity to think about medical ethics. And over 40 of those graduates currently direct ethics programs worldwide, including within the United States, Canada, Asia, Middle East, Europe, and Africa. And we believe that the Ethics Center has made significant contributions, both locally and nationally, to really create and develop the field. So there's the area of bioethics, but really the focus on clinical medical ethics came about through the MacLean Center and Dr. Siegler, really helping to focus the patient-doctor relationship, focus medical care on that patient-doctor relationship, and help develop the model of shared decision-making, which is an area that I'm very interested in and study a lot, but certainly cannot take credit for the development of. The MacLean Center actually developed the idea of an ethics consultation. So when people are routinely in clinical practice and have ethical issues that arise at the bedside, who do they call? Well, they can call an ethics consultation where people come in and sort of help the team and the family have conversations about what's in the best interest of the patient. And there are ethics consults now worldwide. They also developed the idea of a research ethics consultation, which is different. So there are the ethics of clinical care delivery and the ethics of conducting research that sometimes are bigger or different than those that are covered with the Institutional Review Board. And so we also do research ethics consultations either before a project has been launched or at any point during the research project implementation. Ethics is not just something that we think about and talk about in the abstract, sort of theoretical ethics, but it's something that we can also study. And so for me, as a health services researcher, I also try to mix outcomes research with studying ethical projects and ideas. And so Dr. Kumar mentioned that I recently got a Greenwald Faculty Foundation. So for those of us who like to think about ethical issues, know that there are foundations out there who will help you do so in a way that can produce data that you can sort of use to answer questions that you have that are interesting. There's been the development of surgical ethics, so not just within the context of clinical medical care, but also surgical care. And then we have a clinical ethics fellowship training again, which is opened internationally. And every year we have several people coming from all over the world, funded to come to the MacLean Center. So if anyone is interested, we have more information about that on our website. No, I appear to be stuck. Well, is there anyone in IT who can? Okay, never mind. Stay seated. The faculty and fellows of the MacLean Center have written over 175 books, and I highlight here in red A Cancer Companion, one of our faculty members here who's written several books and talked to us over the past several days about many of her accomplishments, some of which I didn't know, and so it's really just been a wonderful honor to hear about some of the things that we can do that have been done from our former faculty, former fellows. And there's also a journal of clinical ethics where we discuss sort of these broader clinical issues. And so that's an area for people who are interested in thinking about clinical ethics that you can write papers and have them published and peer-reviewed. Clinical medical ethics has now become a major component of the American bioethics movement. So it's not, there are two things that are overlapping Venn diagrams, but it's a significant part of it. Now, as a result of the clinical medical ethics movement, many hospitals, most large hospitals in the U.S., actually have either an ethics committee or an ethics consultation service. And so this is something that has happened since the early 1980s. And a lot of the things that we grapple with as clinicians, at least within the United States, have now over time, because of clinical ethics, become part of routine medical practice, how we consider to be what we consider to be standard clinical care. As far as telling the truth, there were times in the past before I started my training where we wouldn't tell people if they had cancer because we thought it was too much of a downer, and so the idea of really being honest and transparent with your patients, having informed consent so people are aware of what they're signing on to when they participate in research trials, having shared decisions about their clinical care, identifying surrogates when you can't make your own decisions, the very complicated and emotional process of death and dying, and how decisions are made for people to be able to die in the best way possible. All of those are things that we now consider to be standards of care in clinical practice, and those come out of the clinical medical ethics tradition. So that's sort of the initial part about just sort of what clinical medical ethics is in the MacLean Center. And the second, the after the colon, about applying medical humanism to patient care is what I'll transition to now. I'm trying to keep, Dr. Kumar asked me to only talk for 45 minutes, and I'm going to try and get that down to a little less than that. So it not only is the doctor-patient relationship, which we spent most of the first day talking about, empathy, trust, compassion, and many other aspects of the patient-physician relationship that have to do with the humanities, but I would also argue that it's humanism beyond clinical care, and that came up on our first day as well, and thinking about our role in addressing some of the social determinants of health that contribute to health disparities, that is part of thinking about people's entire humanity and the social context in which they live in order to promote ultimately good health for everyone, and that is at our very heart an ethical issue for our society, and trying to figure out how to equally allocate resources, both human capital and infrastructure and social capital, to be able to promote equity. So when we think about health disparities, which is I spend a fair amount of time doing, there are disparities within the health care that's delivered. So if you want to impact that, you want to change the health system. But really there are disparities in health status. And what we know is that, unfortunately, for most of us in this room, only 15 to 20% of people's health is affected by the actual decisions we make within healthcare. So the antibiotics that we can provide, the chemotherapies that we can give to our patients, all of that really affects a very small amount of people's overall health. And so if we're interested in improving the lives and health of people, particularly those that are most vulnerable among us, then it really behooves us to think about system change that is outside of our healthcare system, which is why I've turned myself into this hybrid person that thinks about not just healthcare interventions, but things that are way outside of it. Again, I do mainly diabetes research, so this is, I don't know the statistics for India, although I've been collecting them. I started to try and do tell you guys about your own country, then I thought that was ridiculous, and thought I would just tell you about what I know, which is mine. And this is a map of the United States and a map of diabetes, starting from 2004. The darker the color, the higher the prevalence rate of diabetes, and it just you'll just note that over time how dark the map has been getting. And so diabetes is a huge epidemic and problem in our country that's primarily been driven by obesity. And one that I know is a growing problem in developing countries also. And when I was here shopping, as I've done almost every day, one of the people found out that I do diabetes work. And he's like, oh, listen, I've had diabetes for 7 to 8 years. My fasting glucose, and so we went into this like immediate consultation that I was hoping would get me a discount, that did not, about his diabetes.
What state is that?
Oh, so this we should know that the southern part of the country, the southern part of the U.S., is the most obese part of the country. There's a lot of social and economic reasons for that, and so diabetes is chasing the obesity epidemic.
It's like one standout state that has less diabetes. Less data, or is it less diabetes?
Less. Oh, right. So Colorado has much lower rates, but still significant. There are those are population adjusted, so it's per 100,000. This is a map of my city of Chicago, which you'll see there's a lot of regional variation, not just in diabetes prevalence, which I'm not showing you here, but also diabetes outcomes like death. So the diabetes-related mortality varies within the city. Much higher rates, again, darker is higher prevalence, or in this case, incidence and prevalence of these, for the southern parts of Chicago and the western parts, which are primarily very low-income communities with people who look a lot like everyone in this room, so brown and black people. Potential of years that are life years that are lost in Chicago due to diabetes are also mapped on to the southern and western parts of the city. And then also very similarly related, avoidable diabetes-related hospitalizations. So we just sort of know that diabetes in our city is something that is not equally distributed, and part of those associations are based on race and class and other factors that impact people's health. So again, thinking about health disparities and how we want to change things to make them better, we think not just about the health care that's in our city, but also the various things in the society and communities that affect health. So I'm going to talk a little bit now just about some of the work that we're doing in the city to try and address some of the disparities. Again, thinking about this interactive ways in which we've been discussing oppression and trying to empower people in their communities to address oppression. And we had quite an impressive oppressor, I have to say. But it speaks to the difficulty of overcoming these challenges, that change is not without significant effort to address what I call persistent and pervasive disparities. So it's going to really take those kinds of things to overcome change. So the work that we're doing really involves lots of parts. It involves the healthcare system, healthcare providers, so like people in this room, actual people, patients to be activated, and partnerships within the community. And so I'll spend just a little bit of time sort of thinking about the integration of these two, how we as the health system work with patients and community organizations to promote health. So again, one of the things that we do first is to try and identify our hotspot areas which are in increased need. So here is where the University of Chicago is located. Hyde Park, this nice little bubble of decreased diabetes mortality and increased wealth and socioeconomic diversity. But we know that we're surrounded by we're a donut hole surrounded by a lot of high rates of diabetes related outcomes. So one of the things that we did in our project was try and also map the resources that are in this area. So identifying faith-based organizations, primarily, again, this is an African American community, so thinking a lot about the African American churches that are around, some of the health clinics that are around, a part of the Southside Health Collaborative, some of the grocery stores that people use, our farmers market that we partner with, some of the Walgreens. So Walgreens is known internationally. They have their national headquarters in Chicago, and they've been piloting a number of what they call food desert locations, so that for the grocery stores that are the only walkable area where people can access things. They'll bring fresh fruits and vegetables every morning, fresh produce, for people who otherwise wouldn't have access to a grocery store. And so we've been partnering with participating Walgreens that have the food desert location or designation. So we have a whole bunch of community partners. Most of these names you probably won't recognize, but we just work with a lot of organizations that think about food, economic development, physical activity, the built environment, and places where people sort of live and play and work to try and promote health. And this is a picture of just a food pantry that we collaborate with, that we've been collaborating with for the past 3 to 4 years. And so what we do is, while food from the food depository is being distributed, we do a lot of health education, screening for diabetes, connecting people to medical providers who wouldn't otherwise have it, and a variety of things to try and provide a community forum where people can talk about health in a way that they may not have otherwise been doing. In fact, we knew they weren't doing it before. They were just sort of sitting around waiting for the food. So trying to use a number of teachable moments in places where there are already community resources. We work, again, with a number of local low-cost grocers that are located in these communities, and we have trained dietitians and other people to give tours of how to help people shop on a budget. So people who have limited resources but need to buy healthy food, how can you make the most healthy choices for your family on a budget? And so that's part of the work that we do also. We have trained a number of community members to give these tours, and so part of what we do is not just think about the physical resources that are in the community, but the people resources that are in the community, so they can sort of help address some of the problems that we see as far as health disparities. We have prescriptions for food and exercise that we give out that are supported by the vendors. So in this case, Walgreens, that's one of the reasons that we partner with them. Not only do they have fresh produce that they give every day, they have been underwriting the cost of coupons for people to actually access some of those fruits and vegetables. So we work with really closely with Walgreens and a number of other places so that physicians in health systems can write prescriptions for food and exercise. The exercise comes from the Chicago Park District, so Chicago's sort of known for a lot of parks and recreation, but there is usually a fee associated if you actually want to take an aerobics class or use some of the facilities that are the physical buildings on the parks. Within Chicago, we're sort of internationally known now for a lot of our gun violence, and so a lot of people, even though there are parks available, may not feel comfortable walking on the outside of the park. May want to actually go inside the buildings and facilities, but again, there's a fee associated with those. So you can get 6 months with a refill for another 6 months of exercise at the Park District that we've been collaborating with the city's health department for. These are pictures of one of the farmers market that we work with. So a few of the vendors, we took these two because they're people who actually been through our diabetes classes, which I talked about on the first day. This is another example of some of the tours that we give at the farmers market. So this is our team. We set up a tent every Saturday of the year, except for the wintertime when the market is only open once a month. And so these are people who are from the community who either have diabetes or just interested in health, who give tours and introduce people to the farmers. We have cooking demonstrations with local community chefs who a lot of times have family members with diabetes and are from the community and really have a passionate commitment to addressing disparities. We also have tried to integrate some of this work with the existing medical system that we have. So one of our colleagues, Stacy Lindau, has created a program where she has mapped all the resources on the south side of Chicago. And so when people come in with a diagnosis of diabetes, they automatically get, as part of their health summary, resources that are close to them related to their diagnoses. So for diabetes, if you come in and the doctor clicks that you've had diabetes, then you'll get information about some of our programs, and you may actually get a food prescription. And this may be, I'm stuck again. Let's see. Now I think I'm just, this is my last slide. Just to remind me and us that, again, thinking about these broader issues of health is not just about the relationship that we have with patients inside the healthcare system, which I think is hugely important. Shared decision-making, empathy, caring for patients, developing a safe interpersonal space to be able to work with your patients. But I would also argue that it's humanism that extends beyond the clinical setting and what we do to address some of these broader social issues that patients face when they're trying to promote their own health. And with that, I will just again acknowledge the places where I sit and reopen the conversation, not necessarily just questions for me, although I'm happy to take them, but conversation just within the group about some of these larger issues. So thank you for your time.